Hello everyone, this is Dr. Mahi Nazar from the platform Exam Ease, and today we are going to be discussing the topic of the management of the premenstrual syndrome. And for that, we are going to be following the Green Top Guideline number 48. And this topic is for the students of the FCPS, MCPS, IMM, and even for the MRCOG and MRCPI students, because this is the guideline that is followed by the RCOG and by the CPSP and the RCPI boards. So the first step would be to understand that what is exactly the premenstrual syndrome and how we are going to diagnose it. So the premenstrual syndrome is consisting of two type of symptoms. So we can have either psychological symptoms or we can have physical symptoms. So the psychological symptoms could be depression, anxiety, irritability, or mood swings. And physical symptoms could be breast tenderness, which can be called mastalgia, and they can be bloatedness, right? So the important thing to remember is that it is the timing, right? It is the timing and not the type of the symptoms, and it is the degree of impact on the life of the patient, which is important, that is going to support your diagnosis of the premenstrual syndrome. So by timing, I mean that we need to first define that when exactly these kind of symptoms happen and when we are going to call them a premenstrual syndrome. So the timing would be during the luteal phase of the menstrual cycle. So we all know that we have a menstrual cycle in which we have ovulation in the middle of the menstrual cycle, if the cycle is regular at day 14. And after that, after the ovulation, before the next cycle begins, if the patient is having these symptoms, then we can call it a premenstrual syndrome. And furthermore, there are different variants of the premenstrual syndrome, right? So we have a core menstrual premenstrual disorder, and we have different variants of the premenstrual syndrome. So we're going to talk about it later along this lecture. So these are some of the symptoms that you can see in a diagram form, right? We all know about these symptoms. We all have experienced these symptoms, right? So the next thing would be to know exactly that how prevalent is premenstrual syndrome and what is the cause of the premenstrual syndrome. So you can just remember it very easily by a table, right? Which is the table of 5, which is 5 into 8 is 40, right? 5 into 8 is 40. So 5 to 8% women are those who suffer from severe PMS. And 40% is overall the general population who are experiencing mild to moderate premenstrual syndrome, right? Now, when it comes to the cause of the premenstrual syndrome, there's no clear-cut evidence-based, explanation. But there are two theories that are being discussed by the Green Top guideline. One is that some women are just sensitive to the hormones, right? They just respond to the hormones. So we know that the progesterone, it can cause symptoms like mastalgia and bloatedness. So some women are just experiencing these symptoms because they are sensitive to progesterone. And secondly, there's certain neurotransmitters like serotonin and GABA receptors, which are responsive to the estrogen and the progesterone, right? And that is why some patients, they overtly experience premenstrual syndrome. The next important thing to know is the diagnosis. So how do we diagnose the premenstrual syndrome? So it is diagnosed on a diary, which is known as the symptom diary. And that symptom diary has to be completed by the patient prior to the next, prior to the start, prior to starting the treatment, right? And how do we give the patient the symptom diary? We ask the patient to record the symptoms in that diary over 2 consecutive cycles in a prospective manner. Like, we can't do it in a retrospective manner. When the patient comes to us, we give the patient the symptom diary, and the patient is going to record the symptoms over the next 2 cycles and come back to us, and then we can see if those symptoms are getting worse, we can diagnose the premenstrual syndrome. But there's another thing, that sometimes the symptom diary is inconclusive. We don't get a definitive idea whether our diagnosis is correct or not. So for that purpose, we have the GnRH analogs, which can be used for 3 months, because we know that GnRH analogs, they inhibit the ovulation. So they are going to improve the symptoms. So we can give them for 3 months, and if the symptoms are improving, then that is giving us a definitive diagnosis that we are dealing with the premenstrual syndrome. Okay, so the next thing is that what is the criteria for diagnosing the core premenstrual disorder? Like I've told you that there is a core premenstrual disorder, and there are other variants of it, which we will discuss later. But this is taken from the Talk article from 2023, and they say that the symptoms, they should occur in the ovulatory cycles, like they must occur in the luteal phase. So as you can see here, that symptoms are occurring in the ovulatory cycles, they must recur in the luteal phase, and they must be prospectively rated. Like I've told you, we use a symptom diary. And important thing is that symptoms are absent after the menstruation and before the ovulation, right? That after the periods are ending, these symptoms are getting normal, right? So this is how we diagnose the core premenstrual disorder. Moving on, the next thing would be who will treat the PMS, right? So the first thing to understand is that not every other patient has to come to the gynae clinic for the treatment of the PMS, because certain patients, like most patients, as we have discussed, 40% are just having mild to moderate PMS. So they can be treated by a general practitioner. So for that, if there's simple measures like the combined oral contraceptive pills and the SSRIs, they have failed, and the severity is so much that the patient is not improving with these medications, then the general practitioner can refer the patient to the gynae clinic, right? This is very important to understand. And the next thing is that if the patient is having severe PMS, then one thing that you need to remember whenever you're studying the Green Top guidelines, or whenever you are going for any exam, the multidisciplinary team is very, very important, right? So you're not just alone while you're treating a patient, you can have help. So when we are treating severe PMS, we can involve a general practitioner, a general gynecologist, a gynecologist even with special interest in the PMS, and a mental health professional is very important, because obviously this is impacting the quality of life of the patient. So we can involve a psychiatrist, a clinical psychologist, or a counselor, and a dietitian. Okay, so this chart is very, very important, because obviously it looks like a very daunting kind of chart, but it's easy. If you just try to follow what I'm saying and just follow the graphs, it will be very, very easy for you. So the first uh, box that we have, that is the mild premenstrual disorder. So how are we going to study it? So we can see that we have two lines here. One is showing, one axis is showing the day of the menstrual cycle, and the other is showing the effect on the quality of life, right? And we have this little box in the center which is showing M, which is showing the periods. So as we can see that the patient is having a peak right before the menstrual cycle, also here, but it is not very severe. Like it is affecting the quality of life of the patient, but it is not like going that high, it is in the middle. So we can see that this patient is being affected before the periods and having the symptoms, and it is affecting the quality of life of that patient. So this is called the physiological or the mild premenstrual disorder. Compared to it, the next box, if you can see, we have the core premenstrual disorder, which means that the patient is now having severe symptoms, right? So you can see that the peak of the symptoms is very, very high. It is, affecting the quality of life of the patient, and it is happening before the periods. So we have two peaks here, which are suggesting that the patient is having very severe impact on the quality of life, right? So this is known as the core premenstrual disorder. Compared to it, if you see this box, the next box, we have the premenstrual exacerbation. Okay, so this is not basically a very typical kind of a premenstrual syndrome, because if you see here, we have these periods, right? And we are having a peak here. So obviously the patient is having, some kind of symptoms before the menstrual cycle, but these symptoms, this peak is not coming down. This peak, if you can see, it is not coming down. If you can see, compare it with this. Here we have this peak which is coming down. What does that mean? That the symptoms are getting better after the menstruation. But right now, if we see here, the periods are not helping with the, when the periods are ending, they're not relieving the symptoms. That means the patient is continuously having the symptoms, right? So this is known as a premenstrual exacerbation when the symptoms are not relieved, which means that if you can see it here in this box as well, that there is a no symptom free week. Ideally, when you have a premenstrual syndrome, the symptoms have to get relieved after the menstruation. But right now, in this particular box, we are seeing that the symptoms are not relieved. So this is a premenstrual exacerbation. So in that case, the treatment should be any underlying medical, physical, or psychiatric condition. So we need some kind of a referral here, right? Because obviously there's something else which is going on here. Moving on, if we see this one, okay, this is important. This is a premenstrual disorder with absent menstruation. Because why this absent? Because we see there's no M box here, right? So there are certain symptoms, and before the, there is no menstruation. This is an amenorrheic patient. Patient is not having period, but still she's having cyclical pain. So that is known as a premenstrual disorder with absent menstruation, and we treat it as a core premenstrual disorder because obviously the symptoms are cyclical, even though the patient is not having any periods. So the next one is the progesterone induced premenstrual disorder. So this is important because certain patients who have, like, they're using some kind of a contraception like the implant, they're having, so they can undergo these symptoms of the premenstrual syndrome, and they are progesterone induced. So we can see here in this box that we have two little boxes here. If you see, there are two boxes. One is the M, which is showing the periods, and this green box is showing the P. It is not very visible in this diagram, but it is showing the P, which is meaning that the patient is having some kind of a contraception in the form of a progesterone. So here again, the patient is having symptoms before the menstruation, and they are getting relieved after the menstruation, but it is because of the progesterone. So progesterone induced premenstrual disorder. So what is the solution? You consider an alternative for that progesterone. You get some other contraceptive practice, right? Okay, the last one is the, what is this? This is not related to periods at all. This is not related to periods at all, because obviously this is the menstrual cycle. There is no peak before the menstrual cycle. There's a continuous pain the patient is having. There's no cyclical pain. So what do we call it? This is some kind of underlying psychological disorder. So for that, we need to refer the patient to a psychologist. So hopefully this table is clear to you. So we have a core premenstrual disorder. We have discussed that it has to be in the luteal phase. It has to be diagnosed on a symptom diary over 2 prospective cycles, and it has to get better after menstruation. But then there are variants, right? So we have discussed all these variants, and if you just study the chart, carefully once more, you will just certainly get the hang of it and not forget it. So moving on, let's move on. So now comes the management of the premenstrual syndrome. It is very, very important to understand, right? So when it comes down to management, we have to see the kind of symptoms the patient is having, right? And obviously we need a stepwise manner. We can't just prescribe everything, right? We have to go in a stepwise manner. That, for example, you've given the patient some first line measures and they have failed. Then you jump to the second line and then the third line. So we have a proper algorithm for that. But the basic approach towards the premenstrual syndrome is that it depends upon the kind of symptoms the patient is having, right? So we can have psychological symptoms, as we've discussed in the beginning, that psychological symptoms and physical symptoms. So let's just discuss that. So this algorithm is the most important part. This is the most important slide for the premenstrual syndrome, because this is what you need to remember for exam purpose, right? So the first line is, as we have discussed, that the general practitioner can prescribe exercise, can tell the patient about cognitive behavioral therapy, which is the talking therapy, CBT. That can be the first line. The GP can give vitamin B6, and the GP can even give combined generation pill. Okay, now this is very, very important topic, that COCPs are they're different kind of COCPs. So the one that is very, very effective in the premenstrual syndrome is the one containing drospirenone. So that's what you need to remember. Okay, so we need to give drospirenone containing COCPs. These are the new generation COCPs, and they have to be given continuously. Okay, it's better to give them continuously and not cyclically. And the best thing would be to give SSRIs. And when we talk about the SSRIs, you can see here, we can give them in the luteal phase from day 15 to 28, which means after ovulation, right? At day 14, we are having ovulation. And after that, from day 15 to 28, we can give low dose SSRIs, for example, the citalopram or escitalopram 10 mg. So now all of these are first line. Okay, we have exercise, CBT, B6, we have COCPs, new generation pills, we have the SSRIs, low dose SSRIs. So I have told you before that the management depends upon the symptom of the patient. If the patient is having physical symptoms, we can give a COCP as a first line. If the patient is having psychological symptoms, we can give the SSRIs, low dose, as the first line. But the best, if they ask the best, what is the best for the the PMS, it would be the low dose SSRIs. So we have to see what kind of question they're asking in the exam, right? They're asking physical symptoms, they're asking psychological symptoms, or they're just asking what is the best management, right? Or what is the first line management? So first line would be like initial management. So initial would be CBT, obviously, cognitive behavioral therapy, vitamin B6, exercise, right? So we have to understand the buzzwords in the exam. So this is the first line. After that, we have the second line. So in the second line, we can either give, first we were giving COCPs. What is COCP? Basically, combined oral contraceptive pill. Combined means we have both estrogen and progesterone in it. So now we can just change the kind of the estrogen we are giving. First, we were giving oral estrogen, right? When we are giving COCP, it is an oral drug. Now, in the second line, we can give a patch. We can give it transdermally. We can give it subcutaneously. So it is given here 100 micrograms along with a micronized progesterone. So what is micronized? Because progesterone, we have studied that there's a variant in which the progesterone can cause the PMS symptoms. So we can give a micronized progesterone, which means that a very, very small dose of the progesterone is given. Okay. Or we can just put the patient, give the patient Mirena. We can put Mirena into the patient. So it will continuously release the progesterone. So we can have that as a second line. Along with that, we can also do another thing. We can do that, we can increase the dose of the SSRIs, right? Best is the low dose SSRIs, but we can also give high dose SSRIs. For example, citalopram or escitalopram 20 to 40 mg. Moving on, the third line, for example, the first line is not suitable, it has failed, second line is also not suitable, and then we have the third line. So we can give the GnRH analogs. So this is very like a GnRH analogs can't be given for a long time period, because GnRH analogs, they cause what? Very, very important thing to remember. What do GnRH analogs do? They decrease the bone mineral density. They decrease the bone mineral density. So what do we have to do? We have to give the patient HRT, which is the hormone replacement therapy, which is the combined estrogen and progesterone therapy, if we are giving the GnRH analogs for a longer time. And what do we mean by longer time? For more than 6 months. So if we are giving GnRH analogs for more than 6 months, then we have to do some, give the patient some add back HRT in the form of combined estrogen and progesterone. And this is very important. Or we can give the patient Tibolon 2.5 mg, right? And the fourth line, the final one. Okay, the patient, you have been, you have been trying everything is now failed. Now the fourth line is the surgical management. Obviously, when you do a surgical management, what do you mean by surgical management? Very, very important thing to remember. So please pay attention to this part. When we talk about surgical management, obviously PMS is a condition which is mostly affecting the younger population, right? The younger population in their reproductive age group. So surgical treatment means that we can do hysterectomy. We can do hysterectomy, or we can remove the ovaries, right? So the very important concept to remember here would be that, will you remove the uterus only, or will you remove the ovaries as well? Because ovaries are basically responsible for the whole cycle. They're causing the ovulation. Ovaries are just releasing the eggs, and because of the ovulation, the patient is having all those symptoms, right? So do you have to remove the uterus, or do you have to remove the ovaries, or you have to remove both? because now we are dealing with a patient which is very young. For example, the patient is in her 30s and she's having so severe PMS that all the medical therapy has failed and you have to jump to the surgical treatment. So now the question comes, and it's a very, very important exam question, that whether you will do hysterectomy or you will do just BSO, bilateral salpingo-oophorectomy, or you will do both. And you need to understand this concept, that even if the patient is young, you have to do hysterectomy and remove the ovaries as well, even if the patient is young. This is very important in case of the PMS, right? Why? Very important to know why. Because let's say you remove the uterus, you do the hysterectomy, you've done the hysterectomy, right? But the ovaries are still there. The ovaries are still there. So what will happen? There will be ovulation. When there is ovulation, the hormones are being produced. So the hormones are there. So they will be causing the PMS, right? So it will be of no use if you're just removing the uterus. On the other hand, let's say you keep the uterus, but you remove the ovaries. You remove the ovaries, but the uterus is still there. What will happen? You will have to obviously give the patient some kind of HRT because ovaries are not there, the hormones are not there. You have to give the hormone replacement therapy. So when you're giving hormone replacement therapy in the form of estrogen, let's say, it will cause the thickening of the lining of the uterus, which is called endometrial hyperplasia, right? So when you have that, you will have endometrial hyperplasia. In order to combat that hyperplasia, you will have to add progesterone into the estrogen. I will repeat this concept. It's very important that you understand it. You have the uterus, you have the ovaries. Okay. So we have removed the ovaries. What does that mean? No hormones, no estrogen, no progesterone. Only the uterus is there, right? So the patient is not having any periods. We thought that this is going to relieve the PMS. What will happen when you give hormone replacement therapy? Obviously, patient is young, she needs some hormone replacement. You have given her estrogen. It will cause the thickening of the lining of the uterus, which will cause what? Endometrial hyperplasia. And endometrial hyperplasia, in order to combat that, we add to it some progesterone. And we have already studied that there is a variant of the premenstrual disorder which is called the progesterone induced premenstrual disorder. So progesterone will do what? It will worsen the PMS, it will cause more symptoms, right? So either ways, whether you remove just the uterus or just the ovaries, you're still going to have PMS. So this is not the solution. So what is the solution? What is the surgical management exactly? So for that, the surgical management has to be hysterectomy with bilateral salpingo-oophorectomy. Because the patient is young, you have to give her hormone replacement therapy. So this is the whole concept. If you just understand the stepwise medical management of the premenstrual syndrome, and if you just understand the surgical management, because obviously it comes to our mind that, oh, the patient is young, so obviously we can't remove her ovaries right now. So that would be, your answer would go wrong. So the answer would be hysterectomy with bilateral salpingo-oophorectomy. But the most important thing is, if they're asking you a question and you're just jumping to hysterectomy as the first line, that would be wrong. Obviously, everything has to be stepwise. Whenever you study anything, any topic, it has to be a stepwise management. So that is why we have studied a first line, in which we know that there's a new generation COCP, which is the drospirenone. We know that there is a low dose SSRIs, and then we know that we have to see what kind of symptoms the patient is having. If the patient is having physical symptoms, you can go for a COCP. If the patient is having psychological symptoms, you can go for SSRIs. And for example, it doesn't work, then you can step up, then you can go to a second line, then you can go to a third line, and finally you can go to the surgical management. So very important to know that it has to be a stepwise management, and the surgical management is the hysterectomy with the bilateral salpingo-oophorectomy. The final, but not the least thing to remember is that sometimes they ask about the complementary therapies, which can be helpful. So there's a table that we have, in which they have given us, like, some things have a proven benefit in helping out with the PMS. So if you give calcium and vitamin D, it is going to help in relieving the symptoms of the PMS. Other than that, other studies, they show that there's some benefit of exercise, some benefit of evening primrose oil or acupuncture. And for vitamin B6, magnesium, it has mixed results. So just study this slide a little and remember that calcium and vitamin D has a proven benefit in the treatment of the PMS. So that is why we say that an integrated holistic approach is needed, right? So we have studied right now that how to diagnose the premenstrual syndrome, who is going to treat, when you're going to refer, when you're going to have a multidisciplinary team, then the medical management, the surgical management, and the complementary therapies. Finally, if the patient, let's say, becomes pregnant, for example, the patient was taking the SSRIs, the selective serotonin receptor inhibitors, there is a small unproven association with congenital malformations. It is not proven, but it is there. The risk is there. So pre-pregnancy counseling is important. So because if the patient is conceiving with these drugs, then the patient should know that this is a side effect. But the ideal thing is that when the patient gets pregnant, since the hormones are not there, so the mood symptoms, they get better, right? Okay, so the summary is very important. If you just study this summary, it is going to sum up everything. It is going to sum up all the questions that come in the exam. So if you have a basic concept, because in exam what happens is that we study the whole of the guidelines and everything, but the exam is very specific. They're asking you a very specific question, right? They're not asking you like to jump up to the next answer. They're asking you very specific thing. For example, if they ask you mild psychological symptoms is there, and they are asking you initial, what is your initial management? It is not the best management, but it is the initial management. So that would be CBT, cognitive behavioral therapy. If they ask you the best, as we have already discussed, it is the low dose SSRIs. If they say that the patient has symptoms and she wants contraception as well, now she wants contraception, now we know that the best is the low dose SSRIs. But SSRI is not a contraception, and we also know that the first line is a COCP. COCP is also a first line. So when the patient wants a contraception and she's also having PMS, and we need to give her some treatment, we don't just say now that the best is the low dose SSRI, so we're going to give that. Now the answer would be wrong if you give SSRI. The answer would be a COCP. And what kind of a COCP for PMS you have to remember? It is the new generation, the drospirenone containing COCP. Now, if the patient has only the breast symptoms, the breast pain is there, mastalgia is there, then you can give danazole. But with danazole, there is a side effect you need to remember. It is given in a dose of 200 mg twice daily, but it can cause irreversible virilizing effect. Okay, irreversible virilizing effect if the patient gets pregnant. So that you need to remember. And if in the question the patient has breast cancer, let's say the patient has breast cancer and we are giving tamoxifen to that patient, one thing you need to remember for PMS, as well as when we will study the HRT, the hormone replacement therapy, it is that you cannot give SSRIs with the tamoxifen. Okay, you can't give these two things together. So SSRI is the best treatment. You can't give SSRI here. Patient has breast cancer, she's taking the tamoxifen, you can't give her the SSRIs. Since she has having breast cancer, COCPs are contraindicated. That we're also going to study when we study the contraception module, where the UK-MEC criteria. So the COCPs can't be given when it is a breast cancer patient. So the first line is out, the second line is out. The third line, now we jump to directly to the third line, which is the GnRH with Tibolon. We can give Tibolon or GnRH, right? So this is the summary of the whole of the topic of the premenstrual syndrome. So if you just go through these slides and if you just study, once you listen to the lecture once or twice, this is going to be very easy for you. So you don't just need to go through the whole green top guideline and study it to, word to word. If you just follow these, I think these are just 15 to 16 slides. If you just listen to my lecture, this would be more than sufficient. This will complete your whole topic, right? And you don't have to study it from anywhere, not even a single book. You don't have to study any book. You don't have to study green top guideline even. For your own knowledge and for your own satisfaction, if you want to read it again yourself, you can. But if you just go through these slides and just listen to this lecture, it would be more than sufficient. So that's it. Thank you so much. I would like to have some feedback from everybody who goes to this lecture. And if there are any queries, you can post it on my page on the Facebook, which is Exam Ease. Thank you so much.